The focus of this program will be on some of the acute complications of diabetes, such as hypoglycemia, also known as low blood sugar, or an insulin reaction, hyperglycemia, or an abnormally high glucose content of the blood, leading to complications such as diabetic ketoacidosis, commonly abbreviated as DKA, or hyperosmolar hyperglycemic state, or HHS. These will be explained in depth in this program. Those who care for patients with diabetes should also be aware of the monitoring that is required to prevent these life-threatening acute problems and other more chronic complications of diabetes. Let's begin with hypoglycemia. It is a common complication for persons with type 1 or type 2 diabetes. If not recognized and treated promptly, it can cause loss of consciousness, coma, and death. It is ironic that as more persons with diabetes keep their blood glucose levels under tight control to prevent long-term complications, the frequency of hypoglycemic episodes has increased. Hypoglycemia is caused by excess insulin, whether from injected insulin or from oral agents, in relation to the person's food intake and activity level. Insulin-related causes of hypoglycemia include inaccurate dosage, frequent insulin adjustments, irregular timing of insulin doses, and failure to decrease insulin dosage when eating less or exercising more. Some types of oral agents, such as sulfonylureas and meglitinides, may cause hypoglycemia by stimulating the pancreas to produce more insulin than needed. Drugs that people with diabetes take for other conditions may also increase the risk of hypoglycemia. Because of the potential for drug interactions, individuals with diabetes should discuss all the medications they take, including herbs, minerals, and other dietary supplements with their healthcare providers. Food-related causes of hypoglycemia include skipping or delaying meals or snacks, irregular timing of meals, drinking alcohol without eating, and not eating while sick. Increases in physical activity can also cause hypoglycemia. Failing to recognize the need for more carbohydrates when exercising for a prolonged period, and a high degree of variability in a person's activity schedule can also increase the risk. Other factors that increase the risk of hypoglycemia in those with type 2 diabetes are advanced age, poor nutrition, and liver or kidney disease. When the blood glucose level falls too low, there's a counter-regulatory response in the body that acts to raise the blood glucose level back up to normal. Hormonal counter-regulation involves responses by the autonomic nervous system to increase the blood glucose level and counteract the hypoglycemia. Glucagon, a hormone produced by the alpha cells of the pancreas, is the primary counter-regulatory hormone. Glucagon stimulates liver glycogen to convert back to glucose and thus raises the blood glucose. Another important counter-regulatory hormone is epinephrine, a hormone produced by the adrenal glands that rapidly causes a rise in blood glucose by stimulating liver glycogen to convert back to glucose and, in some tissues, decreasing utilization of glucose. Autonomic signs and symptoms that may occur in hypoglycemia are related to epinephrine release and include trembling or shaking, profuse sweating, fast pulse and respiratory rate, and tingling in the extremities. These symptoms, however, may not always be experienced by the individual because of the following sequence of events. After several years of having diabetes, most persons with type 1 have impaired secretion of glucagon. Epinephrine secretion, therefore, becomes the primary mechanism for raising their blood glucose levels. But over time, the hormonal counter-regulation effect of epinephrine too can become defective. As a result, the person may not recognize the warning signs of hypoglycemia and is said to have hypoglycemia unawareness.
Hey, Ben. Okay. Hey, Alex, call for help, okay?
Those with hypoglycemia unawareness are at an increased risk of severe hypoglycemia. To protect themselves, those with hypoglycemia unawareness should test their blood glucose frequently, especially when their levels are likely to be low or when the condition could be particularly hazardous, such as performing dangerous activities, driving, or operating machinery. The blood glucose level needs to be 100 milligrams per deciliter or more to do these types of activities safely. Hypoglycemia unawareness is increased by frequent hypoglycemic episodes, a long history of diabetes, strict diabetes control with insulin or oral anti-diabetes drugs, and drugs such as beta blockers that mask hypoglycemia symptoms. Another physiological mechanism causing signs and symptoms of hypoglycemia is neuroglycopenia, lack of glucose in the brain resulting in a disruption in mental and motor functioning. As the blood glucose falls and the brain is deprived of its energy supply, symptoms such as slow thinking, difficulty concentrating, blurred vision, slurred speech, uncoordination, dizziness, and drowsiness occur. Neuroglycopenia can also cause a number of changes in a person's emotions and behavior, such as irritability, anger, refusing treatment, or acts of aggression.
I'm feeling fine. Leave me alone. Just let me get my job done.
Neuroglycopenia is also the cause of accidents and injuries. If the person's symptoms are not recognized and treated, the blood glucose level continues to fall, causing a worsening neurological state, unconsciousness, and even death. Therefore, early recognition of signs and symptoms and treatment of hypoglycemia are vitally important skills for patients, families, and co-workers. Experts state that hypoglycemia occurs when the blood glucose level falls below 60 to 70 milligrams per deciliter. Symptoms range from mild to severe and are similar for persons with type 1 or type 2 diabetes. However, individuals experience the symptoms at different blood glucose levels depending on how long they have had diabetes, their initial blood glucose level, and how rapidly it is dropping. Some with a blood glucose level of 40 milligrams per deciliter remain alert with only a few symptoms, while others lose consciousness at that level. Most people with mild hypoglycemia or blood glucose of 70 milligrams per deciliter or less can usually recognize and treat it quickly by drinking or eating carbohydrates to raise the blood glucose level. Individuals at risk for hypoglycemia can be taught the rule of 15. Eat or drink 15 grams of carbohydrate, then wait 15 minutes and test their blood glucose again. If the blood glucose level is even lower, less than 50 milligrams per deciliter, 20 to 30 grams of carbohydrate may be needed to treat symptoms. Carbohydrate sources that contain 15 to 20 grams include 4 glucose tablets, 6 to 8 hard candies, 2 tablespoons raisins, 4 ounces of regular soda or fruit juice, or 6 to 8 ounces of non-fat milk. The person should not continue eating or drinking while waiting for symptoms to disappear. Foods and beverages that are high in fat content, such as ice cream, cheese, and candy bars, should be avoided as they slow gastric emptying and absorption of carbohydrates, prolonging the time it takes for the blood glucose level to rise to a safe level. Individuals should always have some carbohydrates with them and should wear identification, such as a necklace or bracelet that can alert others to the fact that they have diabetes. Because those with severe hypoglycemia have significant changes in level of consciousness, they may not be able to recognize or treat the symptoms, so must rely on others to provide treatment. If they are able to swallow without risk of aspirating, they can be helped to drink juice or a soft drink. An alternative is to position the person on his side and place glucose gel, honey, syrup, or jelly inside the cheek. Glucagon by injection can be given to those who are unable to swallow without risk of aspirating. The injectable glucagon is identical to endogenous glucagon and causes a rise in blood glucose. Glucagon's effect on increasing blood glucose is brief, so as soon as the person is able to swallow safely, a carbohydrate source should be given to prevent hypoglycemia from recurring. If the person is unable to safely swallow a carbohydrate source or glucagon is not available, those nearby should call 911.
911? Yeah, I'm at the corner of Alicante and Alhambra, and there's a little girl. She's lying on the pavement here.
Hospitalized patients who experience severe hypoglycemia are given 50% dextrose IV push, followed by oral foods or fluids. All persons with diabetes and their families should receive basic education about hypoglycemia, including an explanation of risk factors, common symptoms, guidelines for treatment, and preventive measures. To review, hypoglycemia is a common problem for those with either type 1 or type 2 diabetes. It's caused by insulin excess and produces signs and symptoms due to hormonal counterregulation or neuroglycopenia. Treatment depends on the level of consciousness and risk of aspiration and includes oral carbohydrates, glucose tablets or gel, glucagon injections, and in medical facilities, dextrose by IV push. Now let's discuss the other extreme, hyperglycemia, a prolonged elevated blood glucose level that can lead to two acute life-threatening crises. The first of these is diabetic ketoacidosis, or DKA. Cal Thomas is unaware that he has type 1 diabetes. He does know that over the past few days, he has been very thirsty and has been urinating much more than usual. He was sent to the emergency department by his family physician and is now complaining of vomiting and increasing abdominal pain. DKA most commonly occurs in those like Mr. Thomas who have undiagnosed type 1 diabetes. It also occurs in those who are known to have type 1 diabetes but are ill, have an infection, or have been taking inadequate doses of insulin. Illness and infection increase the production of adrenal hormones, prompting the liver to produce excess glucose. The risk of DKA also increases for those who take medications that raise blood glucose, such as corticosteroids or higher-dose thiazide diuretics. Regardless of its origin, DKA is caused by a severe insulin deficiency in combination with increased amounts of counter-regulatory hormones. In general, DKA develops rather rapidly over a few days. Untreated, approximately 5% of patients with DKA go into shock and die. DKA produces hyperglycemia, ketoacidosis, dehydration, and electrolyte imbalances. Let's see how DKA develops. With insulin, glucose enters the cells and the body uses it for fuel. Without insulin, the glucose does not enter the cells and cannot be used for fuel. As a result, the blood glucose level rises steadily. As the blood glucose level continues upward, the cells become dehydrated as water leaves the cells by osmosis. Also, glucose molecules spill into the renal tubules, creating an osmotic diuresis that causes large amounts of water and electrolytes to be excreted into the urine as well. Because glucose cannot be used for fuel, the body turns to burning fats for energy. The byproducts of fat metabolism include ketone bodies and other acidic substances such as acetone that lead to ketoacidosis. As the acidosis increases, gastrointestinal symptoms such as nausea, vomiting, and abdominal pain develop. It is these distressing symptoms that often prompt the patient to seek care. Respiratory symptoms are sometimes present and include very deep, rapid breaths called Kussmaul respirations. These hyperventilation efforts are the body's attempt to correct acidosis by excreting more carbon dioxide through respirations. Some patients may have a fruity smell on the breath due to accumulated acetone in the bloodstream. As blood glucose and acids build up in the body, patients develop nonspecific complaints such as headache, fatigue, blurred vision, and increased thirst and urination.
Hey Kyle, how's your pain right now?
Okay, as soon as you get some more fluid in you, that's going to help you feel a little bit better, okay?
Treatment of DKA is aimed at correcting fluid and electrolyte disturbances, giving insulin to restore and maintain normal glucose metabolism, and correcting the acidosis. Once these problems are corrected, it's important to determine the precipitating cause of DKA so that future episodes can be avoided. To review, DKA is a life-threatening acute complication usually seen in people with type 1 diabetes and caused by lack of insulin that results in the body having to burn fats because glucose is unavailable for fuel. Treatment of DKA involves prompt administration of insulin and replacement of fluids and electrolytes. The second life-threatening crisis caused by hyperglycemia is hyperosmolar hyperglycemic state, or HHS.
What brought you in today, Mrs. Sefton? Are you having pain?
I don't think so.
Elizabeth Sefton has type 2 diabetes and lives alone. A neighbor found her quite confused this morning and has brought her to the hospital. Older people like Mrs. Sefton and those having type 2 diabetes that has not yet been diagnosed are particularly prone to HHS.
Very confused.
Also vulnerable are people with type 2 diabetes who do not consume sufficient fluids or monitor their blood glucose levels adequately. Elderly persons who live alone, reside in nursing homes, or are hospitalized are at special risk, particularly if they do not have ready access to water or other oral fluids and sustain an infection like the flu or pneumonia. HHS is a life-threatening emergency with a 15% mortality rate.
How long has she been like this?
Not quite as bad, but about 3 weeks.
Unlike diabetic ketoacidosis, HHS often develops gradually, sometimes over several weeks. It may follow an infection or another medical problem. The characteristic signs of HHS are profound dehydration, severe hyperglycemia, absence of ketosis, and neurological signs ranging from confusion to coma. These signs tend to differ from diabetic ketosis in several ways. Often the blood glucose levels are very high, sometimes over 600 milligrams per deciliter. This occurs because HHS develops slowly, and the prolonged osmotic diuresis and resulting dehydration allows glucose levels to reach these very elevated levels. The severe hyperglycemia caused by HHS produces profound dehydration and subsequent neurological symptoms such as confusion.
Can you look at this, please, and point to the face how you feel? The smiling face means that you don't have any pain at all. No? You can't tell me?
Lethargy and mild confusion are common, and patients may also have neurological signs that mimic a brain attack or stroke. Because there is no acidosis, patients with HHS do not have abdominal pain or Kussmaul respirations. As a result, they do not seek emergency care as quickly as individuals with DKA who experience distressing gastrointestinal symptoms. The primary treatment goal for patients with HHS is to replace the fluids and electrolytes lost and to administer insulin to reduce the blood glucose level. Again, it is important to find out what precipitated the HHS in order to prevent its reoccurrence. To review, HHS occurs most often in elderly persons with type 2 diabetes out of control who sustain an infection. It often causes severe hyperglycemia, profound dehydration, lethargy, and confusion. HHS does not usually cause ketosis, gastrointestinal symptoms, or Kussmaul respirations. Treatment includes replacing lost fluids and electrolytes, giving insulin to reduce high blood glucose levels, and determining the cause in order to avoid future complications. Monitoring the blood and urine of patients with diabetes is a vital part of their care and integral to avoiding acute complications such as hypoglycemia, DKA, and HHS. Blood glucose monitoring, of course, is a cornerstone of this care. Individuals can use blood glucose monitoring results to identify and treat hypoglycemia and hyperglycemia, to make decisions regarding food intake. For example, to determine the effect of food choices or portions on blood glucose levels, and to make medication adjustments when exercising. To prevent long-term complications, those with diabetes should attempt to achieve and maintain blood glucose levels as close to normal as possible. All persons being treated with insulin should monitor their blood glucose levels several times throughout the day. Individuals with type 2 diabetes using oral anti-diabetic agents should monitor their glucose levels often enough to achieve the blood glucose goals recommended by their healthcare provider. Healthcare teams commonly monitor metabolic control by measuring hemoglobin A1C every 3 to 6 months. This assessment is important because hemoglobin reflects a weighted mean blood glucose over the preceding 3 months. In those without diabetes, hemoglobin A1C values range from 4% to 6% in most laboratories, but values may vary slightly. The American Diabetes Association recommends that to decrease the risk of long-term complications, people with diabetes should aim for a hemoglobin A1C level below 7%. The American College of Endocrinology's target is even lower, below 6.5%. Urine ketone testing is also an important part of monitoring for those with type 1 diabetes, pregnancy with pre-existing diabetes, and gestational diabetes. All persons with diabetes should test their urine for ketones during acute illness or stress, when blood glucose levels are consistently elevated over 250 milligrams per deciliter, when any symptoms of ketoacidosis, such as nausea, vomiting, or abdominal pain are present, and when recommended by the healthcare provider. The acute complications of diabetes, hypoglycemia, DKA, and HHS are life-threatening emergencies, emergencies that are almost always avoidable. Healthcare professionals can help patients avoid these complications by making them aware of when they are vulnerable, showing them how to recognize the early signs, and teaching them how to treat the condition before it becomes serious.